Well, thank you for inviting me. I have to apologize to some of the geriatricians. They asked me to give rounds just a week and a half ago, so they're going to see some familiar slides. As always, talking about disclosures right up front. So I have done some speaking engagements for some of the botulinum toxin companies, as there's a new one that's come onto the Canadian market. I've done some consulting work for them as well, and also, interestingly, I was asked by the Department of Justice to be involved in their MAID program, and they have some legal precedents that's coming up here in Canada. I do a lot of clinical trials work, and we have some independent grants that we run through here as well as part of some international collaborative efforts. So, it's a bit of a whirlwind tour of Parkinson's this morning, so I'm going to talk about some of the more advanced treatment options. So I think more and more people are starting to hear about these, and so I'll present a little bit more detail about those. I'm going to talk about the new Canadian guidelines that I've been waiting to hear back from the reviewers, and finally on Sunday I heard back from the reviewers, so I think it's going to be published hopefully in the next month or so when I get all the reviewers' comments back, but they will be coming out soon. And then thought I'd just highlight a couple of the new things that are going to be coming to the Canadian market and some of the things that I think are also going to come. So I think, as everyone's aware, Parkinson's is very common, the second most common neurodegenerative disease. It does affect men a little bit more than women, and it definitely increases as chance of getting it as we get older. And we continue to struggle with how do we diagnose it properly. And so you see this pretty wide variety of figures. And so if somebody presents with a very symmetric disease without a rest tremor, it can be as low as 65%. But somebody sees somebody who's seen a lot of people with Parkinson's, and they present with the classic features of Parkinson's with a rest tremor unilateral with slow progression, then the physician's going to be right 95% of the time. And so that's a pretty wide figure, and we definitely need to do a better job. What are the causes? And the bottom line is we don't know. And so there's lots of things that have been talked about as being causes for Parkinson's. I think for a lot of them haven't been really totally worked out in terms of people as to why that happens. We know that it increases with age. We know that if you run into trouble with your energy producing parts of your cell, the mitochondria, that you're going to get into trouble with those dopamine cells not surviving well enough. Why do men get it more than women? We don't know. There's no question that there's now many genes that have been described as causing Parkinson's, but still it's the minority of patients that we can identify those in. For many decades we've talked about some sort of toxic exposure, but we really, for most people, don't know what that is. Other things, infections, I think have sort of fallen a little bit by the wayside when we think about traditional infections, but we now the idea of a prion, so sort of the mad cow disease theory, and maybe as an infection, maybe that has something to do with causing Parkinson's, where it's an abnormal protein that gets imprinted and it kind of spreads through our body, kind of like the prion protein does in mad cow disease, and this is somewhere that's being actively looked at. And then trauma, how we know that people get significant repeated head traumas that might increase the risk of getting Parkinson's. But again, how does that all come together? I've been showing this slide for now many years, and unfortunately it's the same slide because we still don't understand the process. And so I like this because it looks complicated, and it is complicated. And so there probably isn't one factor for most people that cause their Parkinson's, and it probably is an overlaying different mechanisms with this idea that there's probably some sort of genetic predisposition that why one person gets it versus another. Probably some sort of environmental trigger, but again, we don't know what that is, and it ties then into a complicated cascade of mechanisms that are going to cause eventually cell death. But again, we don't have this all worked out. So I was involved in helping put together the original Canadian guidelines back in 2012, and it had 4 sections to it. And as time passes and many changes are happening, we've come out with the I hope in the next couple months, as I mentioned, the 2019 guidelines. And so I was happy to see that the original guidelines were downloaded more than 40,000 times. These current guidelines were funded by Parkinson Canada, And we did try to get input from most of the players involved in looking after people with Parkinson's. I'm proud to say that this was an Ottawa-led initiative by myself and colleagues here. But we did tie in the expertise of our Methods Centre here in Ottawa. So Brian Hutton was a key person who was very much involved in developing how do we actually do this in a proper methodologic way. And so we followed his recommendations where we did this ADAPT process. So where you look at other guidelines that have been published from around the world and you have a certain scoring system and you look at, okay, were those guidelines well done? If we couldn't find the answer in a guideline, then we look for a systematic review, and if that didn't answer the question, then we finally went to randomized controlled trials. But this is different than sort of a full methodologic review of the topic of Parkinson's that would have taken us years to do. And it's a bit of a way to try to shortcut it and take what other people's work and try to distill it down. So we didn't go to every randomized controlled trial ever published on Parkinson's. We then sat around back in April 2017 and put as much of this together as we could, and then we did it by doodle polls after that, and tried to show and get all these players together to show that, okay, does everyone agree that this is what we should be doing? And in the end, we wound up with 97 recommendations, and you can see it follows a similar outlined to the previous guidelines, although the biggest changes were in the section 4. So this is the non-motor parts of looking after people with Parkinson's. And still, there's a lot of work that needs to be done in this particular section from an evidence-based medicine standpoint. But we did try to make recommendations that we thought would be clinically useful for people, even if there wasn't enough evidence to say 100% that that was the right answer. And then you can see that we added a palliative care section, so section 5, and so thoughts about how we should be doing a much better job in individuals with Parkinson's and their palliative care needs throughout their disease. And so I think for a lot of people, when you look at Parkinson's disease, it looks very straightforward. If somebody presents with a stooped posture, very significant shuffling gait, a rest tremor, they're really slow to do things, and the classic is trying to get up out of a chair. And then, we also, when I'm teaching the medical students this trapped mnemonic, this idea of postural instability, and everyone seems to remember the trapped mnemonic really well, but postural instability is not a part of early Parkinson's. And so if somebody has postural instability, it's probably something else. So this gentleman I'm pulling here in the hallway, he has something called PSP, and I could pull him 400 times and he's going to fall backwards 400 times. And so he really has no balance to keep himself upright, but that's not a part of early Parkinson's. So how do you diagnose Parkinson's? And of course, with most diseases, there's criteria that have been developed. The most recent one were actually developed by the International Movement Disorder Society, and they were published back in 2015, and we thought they made the most sense to us, and so we incorporated into the Canadian guidelines. And it's, I think, what a lot of us had been doing for many years, this idea that you do need to separate out, is somebody have a Parkinsonism, and decide if they have a Parkinsonism, i.e. are they stiff and slow and might have a rest tremor, and then if they have that, is it Parkinson's disease? And I think that's a nice sort of conscious step to take, because a lot of people just jump to, when they see somebody who's stiff and slow, they have Parkinson's. And that's probably not helpful to anybody. And so it's a very conscious thing. Are they stiff and slow? Yes, they're stiff and slow, so they have a Parkinsonism. And if they do, then do they have Parkinson's disease? Because there are many other conditions that can look like Parkinson's. And so the key part of just trying to decide if somebody's stiff and slow is, do they have bradykinesia? And so this is slowness of movement plus they kind of tend to run out of gas, and so they have this fatiguing element, and then they start to get these starts and stops when they're trying to do these rapid alternating movements. And so trying to show that somebody has bradykinesia is really the necessary thing to say that somebody has a Parkinsonism. And so after you've said that, yes, I think they have a Parkinsonism, the second part of this is it gets, as with most things in medicine, a little bit more complicated, but I think it does make sense in terms of, do they have things that might make Parkinson's extremely unlikely, i.e. do they have cerebellar findings, do they have some funny aphasia, do they have significant eye abnormality findings, and so some of the other conditions that sort of mimic Parkinson's disease. Then do they have supportive things? Do they respond to levodopa? Do they develop levodopa-induced dyskinesia? And so these are the sort of the typical things that would, if somebody did respond that way, you'd say, yeah, that's more likely to be Parkinson's. And then no red flags. And these are things like you're progressing too quickly. Like, so if you're in a wheelchair in less than 5 years, what if you're progressing too slowly? And so these things that make something less likely or harder to say it's Parkinson's. And so one of those criteria is actually symmetry. So if you have a very symmetric disease, doesn't mean it's not Parkinson's, but it should make you think about it, because most of the time Parkinson's does present asymmetrically. And then one of the keys as well of these criteria were dementia is not an exclusion. So if somebody presents stiff and slow and may have a rest tremor, and they have a dementia, you can diagnose them as having Parkinson's disease dementia. So this is very different than it used to be, where if you had dementia, it was kind of exclusion, and you had to say, oh, they have Lewy body disease now. And there's definitely an ongoing fight about this idea of what's the difference between Parkinson's disease dementia and Lewy body dementia, and sort of big international bodies are fighting about this, and they still don't agree about it. So I think it is important, if you think somebody's stiff and slow, what are the other things? And so definitely drugs is a big one. So you should always check their medications, and you should always know what those medications are. So there's so many medications out there, it's easy to lose track. And actually my fellow who's been seeing Parkinson patients now for 1.5 years, she got burned because she didn't realize that one of the medications, this person who presented with what looked like Parkinson's disease, was actually a neuroleptic. And so clearly their Parkinsonism could have been drug-induced and not Parkinson's disease, but she just didn't recognize the name of this particular drug. I spend my time trying to sort out these other neurodegenerative diseases, and they can be very tricky to sort out from Parkinson's disease. And I think the last one there, vascular, is a very important thing. And so this is a slide I put together a couple years ago where you think of neurodegenerative diseases, and you can kind of lump most of them into two big categories. They're stiff and slow, or they've got significant cognitive troubles. But I think the important part is that vascular disease plays an element in almost all of those. And so it is very important that, for somebody with Parkinson's disease, that you are managing their hypertension, their diabetes, and all of those things, because that's probably the main thing that might affect their progression. And more we're realizing that white matter load in the brains of people with Parkinson's probably does have an element in increasing their risk of having cognitive difficulties, but also increasing their risk of having balance problems. And so, again, very important to manage those. So we talk about treatment, and so this idea, and again, I'm just going to go through this relatively quickly. I think most people realize that there's lots of medications to treat early Parkinson's disease, and so there's lots of choices. I think for most people, if you don't see that much Parkinson's, there's nothing wrong with just using levodopa. So you can just forget about all these other things that are available, and more we realize that levodopa is the gold standard, and there's really nothing toxic about it. And so this idea of the levodopa sparing strategy is falling more and more to the wayside. And so even for younger folks, I'm using levodopa more and more. So how, if you were thinking about using a different medication, how might you think about this? And so this is what looks like a very simple diagram, and but because there's no evidence-based medicine standing behind it, in terms of there's not a lot of direct comparison studies between these different compounds in these categories, it's actually hard to produce this kind of chart and then have 75% of your colleagues agree to it. And so, but I think, if you ask any one of them, they'd all say the same thing. There's no question that levodopa is the most potent drug that we have to improve the bradykinesia of Parkinson's. It also, though, is associated with the most chance of developing motor fluctuations. So the idea of having troubles with the wearing off and dyskinesia. It does, though, we realize more and more, have less side effects than the dopamine agonist. And so I think in the geriatric population, that is the biggest issue with trying to use a dopamine agonist. You're much more likely to make somebody confused. You're much more likely to drop their blood pressure if you're using a dopamine agonist over levodopa. And for all of us who have been using MAO-B inhibitors for many years now, so these are drugs like rasagiline or selegiline, they are quite mild medications, and so it's hard to get into trouble with side effects, but it also doesn't tend to have a really robust effect either. And so this is just another way of sort of saying the same thing, that if you have Parkinson's disease, you can use levodopa across the whole disease, and you really can't say that about other drugs. Amantadine you see there listed is sort of, sometimes you can use it early, but it's definitely not recommended and in the guidelines as being an early medication to be using. And then I really wanted to focus more on the idea of, well, what is DBS and duodopa about? And this stems from the fact that, as Parkinson's progresses and people have been on levodopa for a longer and longer period of time, they get more and more trouble. So I think a reasonable figure to remember is 10% per year. So starting year one, when you start somebody on levodopa, they have a 10% chance of developing some wearing off and or dyskinesia like this gentleman is showing. And again, to try to help with that, we get into these, again, very complicated looking flow diagrams, and this is one I put together a few years ago to try to simplify the idea of how do you treat Parkinson's, and again, using different drug combinations. And I don't want to go through this in detail, but just the idea of the slide is to show that it can get very complicated in these nuances of trying to treat Parkinson's, but at the end of the day, we're left with not having enough medication options to, I think, make a big enough difference for people, and so we start getting into all these little tweaking things that we're doing. One of the big limitations of all these treatments is dyskinesia, and so this idea of, okay, what's the most effective treatment that we have available for treating dyskinesia? And I've asked this to medical students, I've asked this to residents, and I've asked this to my colleagues, and it's one of those, I don't know, I'd say trick questions, but people, you got to read the fine print, and so it's the most effective. It's not the most common. So the only drug option that is available that helps decrease dyskinesia is amantadine. Any other Parkinson medication, if you cut it back, it'll make their dyskinesia better, but that's at the sake of causing more stiffness and slowness. And then the only other treatment options we have is really either duodopa or deep brain stimulation. And so this ties into the third section of our Parkinson guidelines, where we talk about sort of surgical options. And so these are two potential things that could be considered. So deep brain stimulation, and this idea of putting levodopa into a gel form and then infusing it into somebody's stomach. So I think lots of people have heard about deep brain stimulation, and it really is, that's what it is. It's sort of opening up a burr hole in somebody's head and sticking a wire down deep and then stimulating that area of the brain that you are hoping to interrupt this flow of abnormal information. And so these contacts that we put in have, the current ones that we're using have these 4 different leads on the end, and so it's, you can program in 3 different parameters across 4 different leads and use many different combinations of those, and so you can get into some pretty complex programming issues with those, with these devices. It is important to remember it is a surgical treatment, and so it's not a big surgical treatment in terms of people come in, but you got to drill a burr hole, so you got to get through the skull, and then it's a full day in the operating room. And so this is a gentleman who's behind the OR equipment, and you can see all these fancy probes sticking out the back of his skull. And the idea is that these people who get this done, they need to be awake. And so this person has all these contraptions hooked up to their skull, and trying to find where these cells are hiding, and we need them to be able to respond while the surgeon's trying to find this right area in the brain. And so it can be a very long day. And so you can imagine you have to be pretty cooperative. And this is one of the reasons why somebody who has some cognitive difficulty is not a good candidate for this, in terms of it's a long day, being awake in the operating room, Now, our surgeon uses a more advanced fixation, so some centers, your head is actually fixed to the table, and so you can't move for 6 or 8 hours having your head screwed to a table. Our surgeon uses a device where the patient can still move their head around, but again, it's a long day in the operating room. And so there has been now very good studies done. This is one of the classic ones published more than 10 years ago that showed that if you stick these electrodes into somebody's brain, you can help their dyskinesia up to 70%, you can improve their on time by almost 70%, and you can decrease their medication use by more than 50%. So significant benefits to their Parkinson's symptoms, but again, it is an operation, and it's not without side effects. And so the surgical side effects, I mean, the surgeons now quote, any permanent problems of significance, usually less than 1 or 2%. But there is in this particular study and review published more than 10 years ago, a risk of having intracranial hemorrhage, having infections, having seizures. But again, the really bad things are relatively uncommon. It's hardware, so you could have hardware problems, so it could break, it could get infected as well. And sometimes people can struggle with the battery pack kind of pulling on their chest a little bit, so it looks just like a cardiac pacemaker underneath your clavicle. And then probably the biggest limitation are when you then turn it on. Can we program enough that we can improve their symptoms and not give them side effects? And probably the most common one that runs us into limitations of how we can program is speech. And so running into speech troubles after. Interestingly, this operation can cause a lot of weight gain, and so there has been some patients early on who were significantly overweight, and then when they had the DBS, put on even more weight and got themselves into real trouble. Depression, we've realized, can occur very suddenly, and there was a couple of suicides early on, and so it's important as sort of a pre-surgery workup is to have a psychiatrist involved. So who's a good candidate? So certainly you have to have Parkinson's. So the atypical Parkinsonism is not a good idea. It's important to remember that the surgery improves them to their best that their medications do. So when they're best on time, that's kind of the effect they're going to get from the surgery, except you can eliminate the dyskinesias because that works in a little bit different way, and their tremor. So their tremor, if somebody's very tremor resistant to the medication, that can still respond. But the things like their walking and their overall speed, the surgery is going to make them as good as they are and their best on. So you want typically people who have a lot of trouble with their medication flipping on and off. You really don't want any significant cognitive troubles. And actually, this is a device that requires some upkeep and thought, and so having someone else available to help out is a key part of the success. And obviously, it's an operation, so you don't want them to have lots of other medical problems. And the question of age. So I think a lot of centers kind of use 70 as a cutoff, but we all know that there's fantastic 75-year-olds out there who are probably closer to a 55-year-old. And so it's not an absolute cutoff, but after 70, the surgeons start getting a little twitchy and start thinking maybe this is not such a good idea. So you really have to be a very good over 70 to qualify. So what's Duodopa? So Duodopa is been available in actually Europe for actually a couple of decades. And the idea is that you're just trying to give somebody the levodopa in a continuous way. And there's been lots of attempts at this since levodopa was invented more than 50 years ago. But this is the one that's really been identified to be the most successful to date. So you take, the whole idea is basically just to concentrate the levodopa into a gel. And so you basically get 20 tablets of levodopa into a 100 milliliter container. And then you actually have to infuse it into their jejunum. And so this is a surgical technique, and you need basically a peg tube placement put in. So again, the idea is that you then infuse this gel form of levodopa for 16 hours in a day. So not all day long, or not 24 hours, but for 16 hours. And you can titrate it to a milligram per hour dose, and patients can hit a button and give themselves a little boost if they want to. And so the whole idea is to find that sweet spot where they're on and mobile, but not too on and dyskinetic. So there's definitely been studies that show that it improves on by at least 4 hours. The trouble is the equipment. So it's a tube, it's a pump, they got to change the cassettes, and then you've got a tube that's running around into the jejunum, and so they get these abdominal complications. And so this is not something that most clinics can take on, and so you really need to be part of a subspecialty clinic, and so there's a huge amount of nursing help that's needed to keep these patients going. And again, the thought was maybe this would be a good idea for people who had significant dementia. So they're not good, you don't want to be putting electrodes into their brains, but you can imagine if somebody's a little bit paranoid or a little bit confused and they got a tube and they got a pump, and you could imagine, and so it's turned into a disaster when they've tried this in patients with significant cognitive troubles. They just start pulling and everything, and it, again, not a good option. So which patients are good duodopa patients? And so again, need to have Parkinson's disease, and again, it's the idea of you're trying to help the motor fluctuations. It's not a treatment that if somebody comes into the hospital and they can't swallow for a week or 2 or 3, that you just stick this tube in and then they magically get their levodopa. It's much more complicated setup. You actually can't use this tube for anything else. So it's not like you could feed them for an hour and then start their medications for an hour. So it doesn't work like that either. So again, it's not a good sort of a short-term management solution for people. And so these programs are actually led by my colleague, Dr. Mistre. And so we've been doing the deep brain stimulation here again since 2013, and the duodopa since 2015. But again, you need a whole team involved. And so we have our nurses involved, we have our neurosurgeon involved, we have a gastroenterologist involved, and as I mentioned, you need to have psychiatry. You need to make sure somebody's cognitively capable of ongoing this, but it really is our nurse, Jennifer, who is really the centerpiece of this and keeps the operation flowing well. So duodopa, although been around since 2015, again, it's a treatment that's really a niche treatment. And so we've only had 20 people who have signed up for the program, and 13 that continue on it. We've definitely run into troubles with the PEG equipment, and we've had 4 people stop. Even though we pre-screen a lot of people, we have had 14 people actually go through the whole screening process and then at the end say, we don't think you're a good candidate for it. So it is a very involved procedure. So we often get the question of which would you choose between those two, and it really does boil down for some people, patient preference. Typically, the younger, more active patient who's trying to do a lot of things, probably the DBS is probably a better option because with the duodopa, you're hooked up with this pump and limited by the pump and its maintenance. And so, but there is certainly a lot of overlap between the two potential treatment options. Okay, so what about some new things? So it is still an uncommon, those kind of advanced treatments, although are very effective for helping people with Parkinson's, it's still the minority of patients. And so we now follow with their DBS. I didn't show, but we have now 80 patients who we follow here in Ottawa who have had deep brain stimulation for Parkinson's as well as for tremor and dystonia. But again, that's out of the thousands and thousands of patients that we see with these conditions. So again, we need better medical treatments. And so there is a few things that we think are going to potentially be coming to the Canadian market. There's another COMT inhibitor. I think it's not going to be a game changer. It looks like it's very similar to what we've already got. So it's a bit of a Me Too drug, so similar to entacapone. I've been a little bit surprised. I was working on this compound many years ago, and it is available in the States. And so this whole idea of why don't we just take levodopa and we package it better? We put it in a better pill form. We've had levodopa or Sinemet CR for many decades, and it just turns out that it's not a very good slow release compound, and so we're tending to use it less and less because of its erratic absorption. But there's now 2 companies that come out with much more modern kind of slow release formulations. The one that seems to have a bigger market share in the States is this one called Rytary, and it is very useful. So it kicks in quick like regular levodopa, or relatively quick like regular levodopa, and then last longer. But it really doesn't seem to be a lot of appetite to try to market it in the States. And I think the biggest problem is that it's levodopa. And so would you pay 10 times more to take that tablet compared to regular levodopa? And I think that's the problem in the States, is that people are going, that's a lot of money to take a few less pills a day. And I think that's really why it is not taken off. And then there's another compound that they're looking at, might come to the Canadian market, called sulfonamide, and it works mostly like an MAO-B inhibitor, so again, a bit of a Me Too drug, but it has this whole idea of it also seems to work on glutamate in the brain, and maybe it actually can work without worsening dyskinesia. That's still a maybe, but again, it's something that we're thinking might be an option for the people with wearing off. There is a new category of drugs that has now come onto the Canadian market, and so this is sort of this idea of rescue treatments. I think for all of you who've seen people with Parkinson's, they have trouble where all of a sudden they don't seem to be able to move, and they take their levodopa, and then it takes them an hour or more to get going again. And so wouldn't it be nice if they could take something that then gets them faster quite quickly? And so this is kind of this new category we call rescue treatments for Parkinson's. And so this is for people who have sudden and unpredictable off periods. And the one that's on the market right now is called apomorphine. So this is an injection, and it's only just come into the Canadian market, and I've only got one patient who I've started on it so far. But the idea is that it works very fast. And so the apomorphine has got nothing to do with morphine, but it is a dopamine agonist. And so I think in the older population, this is going to be a potential problem. The other issue is it has a very strong GI effect. So we actually have to pre-treat people with domperidone for 2 days before they start this. And again, it's unfortunately a little more complicated. So they actually have to come into the clinic, and we actually have to figure out which dose they can inject themselves with. And so this takes a little bit of fooling around to get it going. And so the very first patient I had came in, young guy, quite severely off. And I must say I was very impressed. He went from being stiff and slow and hardly being able to walk with significant tremor, and he was actually almost a little, he got his dyskinesia within 10 minutes of taking this. So quite potent. It doesn't last very long, but it can get people over that kind of sudden immobility. There is going to be a sublingual form of apomorphine. So again, most people don't like the idea of giving themselves a needle, but it is, the needle involved, is now, it's like the diabetic insulin. I mean, it's just the smallest little prick, and people really hardly even feel it. And then there is another medication. I was involved in some of the clinical studies with it. So it is inhaled levodopa. So again, people have looked for a long time are there ways of giving levodopa that it can work better? And so they've developed, basically it looks like an asthma puffer, and you take a big breath in basically of levodopa, and you try to absorb the levodopa into your lungs. And it too seems like it works within about 10 minutes. The big knock against it, it doesn't seem to be that potent, and so there's some question of whether some people might need to take 2 shots to get going. But again, this idea of this new group of rescue therapies. And again, these have been shown to be effective in large phase 3 trials. And so again, this idea of it kicking in within 10 minutes. And it's really not supposed to get people on for prolonged periods of time through the day, but just kind of get them to their next dose when hopefully that will kick in. And so the average increase in on time per day was only about an hour. But again, it's this idea of rescue treatments. So, what about some other treatment options? And so some of these things in terms of where are we going with the non-motor features of Parkinson's disease. And I just had a couple of slides in this category. And I think everyone's aware that as Parkinson's progresses, we're usually very good early on in Parkinson's in treating the sort of motor symptoms. And unfortunately, over time, the non-motor features become a bigger and bigger problem, and our treatment options, unfortunately, for those get less and less. And so this idea of more orthostatic hypotension, definitely in your population, the idea of more and more cognitive troubles, but also lots of other sort of non-motor features of Parkinson's get more and more disabling and more limitations of our treatment options to improve them. And it is important to remember that when you're seeing somebody with Parkinson's, a lot of these things are levodopa resistant. So obviously the dementia is, the speech balance problems, this idea of on-period freezing, pain can be a bigger and bigger problem, and then the autonomic troubles. And so you can see this gentleman, the back of his shirt is soaked. And again, this can be a really disabling problem for a lot of people with Parkinson's, where they have to change their clothes many times in a day because of this lack of autonomic control, and all of a sudden they just burst into this massive sweating. This gentleman also has significant troubles with orthostatic hypotension. And so this is one of the flow charts that we came up with in the guidelines. And I'm still surprised that, you know, when I have the students in the clinic, that they, you know, somebody's having a lot of trouble with orthostatic hypotension and they missed that they're, you know, still on a beta blocker or their ACE inhibitor or something. And so, you know, always make sure you've looked at all the other medications and all the other potential inciting factors. Obviously, alcohol is a big one. Caffeine can be a big one in terms of the aggravating factors. And then the trouble with the non-pharmacologic things, so this is like stockings and stuff. When you look at the studies for those, they don't work that well. A lot of them, you had to have thigh-high stockings and an abdominal binder to help with their orthostatic hypotension. You can imagine somebody who has more advanced Parkinson's disease putting that on every day is not very likely to be successful. But more and more, we're using more and more domperidone. And domperidone's really taken a heavy hit in the literature over the last 10 years with this idea that does it have an increased chance of causing death? And the literature about this is going, you'll see one study that says yes, one study that says no, and there was a recent publication from last year that seemed to say, yes, it does. As I've talked to residents and my colleagues about this, when you look at the study, my biggest issue with it is they assume that everyone's using it for their GI upset. So you're using domperidone to help with some nausea. But if you're using it to help somebody who has autonomic instability and has a lot of trouble with orthostatic hypotension, that's a different patient population. And they're clearly, just by definition, going to be more advanced and more likely to die. And so my basic issue with these kinds of massive meta-analysis studies is that they're just, it's the wrong, they're interpreting the literature wrong. And so personally, I think there's really no good evidence that domperidone increases mortality, despite the Health Canada black box warning. But so use a lot of domperidone to help with the orthostatic hypotension, and then if not, then we're looking at sort of the more potent drugs like midodrine or Florinef to try to help boost the blood pressure itself. So another thing, talking about psychosis, and I bring this up because there's a new potential treatment option. I think for most people, quetiapine, they're aware, is sort of the most used drug in this patient population. But again, there's not great evidence that it actually works. But we don't have really anything better that we can use easily. And so clozapine is one of the older atypical neuroleptics, but nobody wants to use it because you have to use this. You have to basically have weekly blood work done. The idea of cholinesterase inhibitors, and I think a lot of people, and I do it too, you're kind of, somebody's got some dementia, they're having a little trouble with hallucinations, they, well, okay, I'm hoping if I start them on their cholinesterase inhibitors, I'm going to help their psychosis as well. Again, not great evidence, but we try that a lot. And then the idea of pimavanserin. So this is actually a new drug that's not on the Canadian market, but I think will come in the next couple of years. And it still fits into, they still call it an atypical neuroleptic, although it tends to work more on the serotonergic side of things. And it has been shown in large randomized placebo-controlled trials. There was some question when it got marketed into the US, because it is available in the US, that it might increase mortality, but again, it turns into the same idea. Patients who are taking this have more advanced disease and are more likely to die, and so yes, there's more people who are dying who are on this, but there's no evidence that it's from the drug, they just have more advanced disease. One of the other questions is, how potent is it? And there's been some follow-up studies saying it has reasonably good efficacy, and it is safe to use as well with cholinesterase inhibitors. So, there's a lot of things happening here in Ottawa, and so this is a very busy slide, but really just trying to highlight that there's a lot of treatment options that we are trying to develop for people with Parkinson's. And so the first one, GBA PD patients, so these are patients who have Gaucher's mutations, and it turns out that that is the most common genetic mutation that causes Parkinson's disease. And so where there's a compound that actually directly inhibits, we think, what's going wrong in these people who harbor this particular mutation. And so we're doing a study with that we're hoping will have an effect on disease progression. More and more in neurodegenerative diseases, we're looking at treatments that can have an effect on these abnormal protein accumulations. So there's been a lot of work in Alzheimer's, but also we've been doing some work in sort of this Alzheimer cousin called PSP. And again, this idea that we can have these compounds that can clear out these abnormal proteins. We're actually just starting a Parkinson's dementia study looking at, can we have a benefit on cognition? And it's interesting, this is actually a dopamine agonist. So it's a very selective D1 agonist that they think, and we're hoping will have an effect not just on the dementia side of things, but also kind of improving those vague troubles of fatigue and somnolence and those kinds of things. And so we're hoping that it's going to have some benefit. Isradipine is a calcium channel blocking medication that we're hoping would have an effect on disease progression, and that study's just wrapping up now. We have a very large study sponsored by the CIHR looking at depression. And so this is looking at psychotherapy and whether that can play a role in treating individuals with Parkinson's disease and their mood. And again, we don't typically like to add extra medications to people who are already on lots of medications, and so we're hoping this will have a benefit without needing them to start a drug. I'm going to mention our integrated care study in a minute. We're doing some studies looking at sort of collecting data, this idea of do-a-dopa, and is there other ways we can use it? Bit of a black box can of worms. We are going to be starting a cannabis study looking at pain in Parkinson's, and so it's one of those very in vogue things, and so it's maybe partly the funding agencies, it's easier to get money if you're going to do some work on cannabis, and so we're looking at seeing if there is any role, because every clinic I have, somebody's going to ask me about cannabis and whether it's a good idea in people with Parkinson's. And then some other local studies looking at drooling, looking at imaging, and where they can play a role. So we've been working actually for a few years now on what we're calling our Integrated Parkinson Care Network. And this is something that's a growing project within the clinic, and we realize that our care of our Parkinson patients is very inadequate, and so I feel guilty every week when I see somebody in my clinic and I say, well, okay, I'd like to see you back, but I don't have another appointment for 10 months. And so definitely not ideal care. My wait list to see new people is pushing now close to a year, and so again, not very good. And so can we do a better job using technology, but also using and trying to give people more support? And so we've developed these modules where we're trying to improve self-management and the tools that people need to improve their own care, and also provide them in resources. And so, as you're all aware, it's continued sort of landmines of healthcare, and where do people get it, and how do you access things. And so we have a care coordinator who helps people navigate through this. And then obviously, can we use technology to help us with this? And so, we struggle with medication lists, I'm sure as you do, and certainly I'm hoping that the MyChart option here at the Ottawa Hospital is people are actually going to follow their own medications a little more carefully, and when you come and see them, they actually have a very good list of things that they're on, and then we can directly incorporate that into their charts. And so we're also looking at ways of monitoring patients better. And so can we collect information from their own home environment of how they're fluctuating on a hour-to-hour basis, or the things that they're doing in their own homes, And so again, can we use technology to help us with that? And we're trying to build a new platform that patients can access and access, what's going on in their community, but also their own help them manage their own health better. So as a wrap up, just a few key things. So I'd like to highlight again that dementia is not an exclusion criteria now for Parkinson's. There are advanced treatment options for individuals with Parkinson's disease, but there is real limitations to those treatments. I'm hoping that people will find the 2019 guidelines helpful, and I highlighted a few of the things that are coming down the pipe in the new treatment options that are definitely necessary for Parkinson patients. This is the Canadian Movement Disorder website that I think if you're looking for a resource to access movement disorders in general, and then we link to most of the other main websites, and so it's www.cmdg.org. And so again, I think the older Canadian guidelines are on there and the new ones will. And so as we wrap up, this is one of my Parkinson patients who unfortunately now has died, and I think it highlights a few things. One, when I first saw him, he was very robust. I think the first time I saw him, he came in leather pants. I think he was still riding a motorcycle. 10 years later, he's now having cognitive troubles. He's with his wife. He has balance troubles when I shot this video. And we definitely need to do a better job of coming up with treatments that affect Parkinson progression. And again, maybe we don't need to hit a home run, but if we can, slow it down by even 30%, I think we'll be a lot farther ahead. Thank you.